This is Alan Winter. We're back again this week to continue our discussion about AI in medicine and specifically how AI can help access. Last week, we talked about scheduling and how important it is because it sets the stage for how the office works. And in addition, we talked about how we're going to look at the different roles that the team members play today as I introduce my colleague, Charles Zelnick.
Hi there. Yeah, we talked a lot about the Swedish nurses study last time, where the nurses were found to do a whole lot better when they were given some support with clinical history taking software. And we want to expand on that talk today by talking more about the levels of healthcare and how we should think about what patients need in relationship to how we move them through the workflow in the office.
I think it brings out an important functions. Why do we need to keep a human in the loop? Well, it could be because healthcare is being treated as one kind of a model, and it's really three. And this comes from Clayton Christensen at Harvard Business School in his book, Innovator's Prescription for Healthcare. And what he did was he divided up illnesses into three categories. One he called value healthcare. And these are diseases that are known symptoms, known diagnosis, a known treatment, a known outcome, and a known cost, like sinusitis, influenza, cystitis in females, erectile dysfunction. These illnesses don't need a physical exam. And actually, we wrote a piece of software back 25 years ago that actually would handle these illnesses and recommend treatment. And it was actually implemented by a clinic on the West Coast. And they wouldn't let us tell anybody that they implemented because it had made their online nurses instantaneous in terms of responding to patient calls. And they were in competition with other medical groups, and they were really very successful as a result of using this software to basically screen for these simple ailments. And I think that's a lesson in how AI is really going to help us if we can use it for these illnesses. And sometimes you see it as the illnesses that you see e-visits are used for, but we aren't triaging it in a practical way to get the patients into using these systems appropriately.
I want to say that the first category you had too, the value healthcare, that's what the EMRs were already designed to take care of. They all come with templates that say this patient comes in with a urinary tract infection, and you can click the boxes, bing, 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 and document it easily. That's the patient you don't see very often in the office.
The second form of healthcare model is really what Dr. Christensen calls network healthcare or chronic health problems. And you've seen this, Charles, in terms of how this should be taken care of.
Yeah, I mean, this is what you mostly see in geriatrics and in any primary care practice. Half the patients or more that are coming in have chronic health problems and need to be seen on a regular basis. Diabetes is certainly the biggest model of this. We have specific guidelines about what we should be doing to help patients with diet and exercise and blood pressure control and taking care of their kidneys. And that needs to be done every so often. Blood tests need to be done every so often. So this is something that you can build into an algorithm, a schedule that can be done on a regular basis with pretty specific guidelines and rules to go with. And so that's a big part of primary care. And that is actually the part that I used to do in concert with my nurse practitioner or with my physician's assistant in the office. A lot of times I'd have a complicated geriatric patient, and they would see them one time and I would see them the next time, and we'd leapfrog back and forth. It took some talking between us and some communication, but it allowed me to extend my chronic care to a larger pool of patients by having an assistant helping me manage those complicated patients. Most of primary care is this chronic care, or it's the third category, which is it's something new that we don't know what it is, and we have to make a diagnosis and develop a treatment plan from scratch, what you call solution healthcare. And I think we're going to talk about that a lot more detail next week, because that's a whole another topic in itself in terms of trust, in terms of um, uh, using an AI in a way that produces quality, but also does it in a way that helps us have access and trust in the system.
And I think if we thought about how AI could work in these, if we divided healthcare this way, is I think AI could take care of uh, the first uh, the first group pretty nicely. The tests haven't been done; it hasn't been validated, but I know it'll work. The second, I really agree with you that the nurse practitioners that I've worked do a better job of chronic health problems than really I do. I mean, honestly, it's nice to see the chronic patients and and see them uh, on a regular basis. But I think I think my nurses actually are better at patient education and spending time answering all the questions about details of how they should care for themselves than really I am. And yet the third category, the solution healthcare, is really where you need a doctor. And I think when my nurse practitioners have seen patients like this, I have to see them anyway, because many times they're just too complex, and oftentimes because they don't actually care for these kinds of patients in the hospital, they don't really know the first step to take, and that's why these illnesses are especially going to not be appropriate for patients to care for it on themselves. So I think
Yeah,
as we
these are the patients. The physician's assistant comes to me and says, "I need some help with this," and I say, "Wait a second, let's pull up to date together and take a look at it." And the patient needs to come see me, and we need to put some thought into it. So these are the people who really want to get to a physician, to a primary care physician, uh, to get things figured out, and make the best use of that training and that experience.
absolutely. Now, the sad part is to this is that many times in organizations, what happens is the physician is scheduled for months in advance with the chronic care patients, and then the nurse practitioner is left to see the patients who call in that day and might have a more serious problem, and and then they have to refer that patient to someone else to see, or they're delayed in care. So sometimes that doesn't result in the best outcomes that would be better by improving the scheduling, goes back to whether AI will have this ability to intelligently schedule, and whether an open scheduling system is actually going to be best.
So as we're talking about how the patient moves through the office after being triaged by the nurse, I want to come back to this slide, which we talked about last time, the river of demand, that there are a lot of different needs for healthcare that patients have, and only capacity for 16% of them to actually see the physician. So this has been the topic of a number of articles, a series that's been called "The Ongoing Crisis in Primary Care" in the New England Journal of Medicine this last year, and I would recommend that for anyone that wants to read more about why there is more demand and also limited availability for physician appointments, and also particularly I want to focus in on teams today. So when we look at the demand again, just to review, a large chunk of the demand is blocked access, which we can't do anything about. A system fix is needed for problems of prior authorization and people being uninsured or not being able to get in on time. But then the next big part of the river of demand can be met by mid-level clinicians and by offices that work on their workflows to get the patient's needs seen at the right level at the right time, as we talked about some with the triage last week. Um, and then when we come down to the physician, there may be ways we can improve the efficiency of the doctor in the office and allow them to spend more time focusing on patients and less on administrative work and other issues that slow physicians down. And we'll talk about that at a future discussion. So let's talk about primary care teams and how the team can be redesigned. So the future is not going to be, will your doctor be a robot or not? The future of primary care is going to be the physician who can't do everything by themselves anymore, and their team with the help of AI and redesigned workflows. So this is going to require a big change in roles for people in the office. And what we've heard administration saying for many years, for decades, is that everybody needs to be trained to work at the top of their license. So this means that if you're a registered nurse, you're doing registered nurse types of things that nobody else could do without your level of training. And if it's something that's um, administrative, or if it's just writing things down that somebody at a lower level could do. Taking vital signs, for example, doesn't require an RN, an MA, a medical assistant can do that. Then you need to be working at the top of the license. The difficulty with this has always been a matter of staffing and training, in that you just get your nurse or your MA trained the way you want them, and they go off to nursing school. My MA, this example I had in my office, I had an MA who was just great, a wonderful young woman, um, who would come back into the workforce after raising some children. She was my MA. I got her trained to do MA work, and she decided to go to nursing school, and we supported her with that because we need nurses. So while she worked as my MA, then she went to nursing school, and then we moved her up a level. So then we had to train another MA. And this is a good thing that we need to do in healthcare systems, but we also have a challenge when we do that, because in terms of training people, then you have to train somebody else over again to do the job correctly. Where AI can help us with that is by providing at the bedside or at the point of care guidance for that type of role. Of an MA doing things besides rooming and vitals and prepping the appointment, you could have your medical assistant also helping your patients as a care navigator, helping with digital workflow coordination in terms of getting your patients to do their histories online or prepare for their visit ahead of time with pre-visit planning. And then your nurse can, instead of just doing vital checks or giving medications, your nurse can actually do the things that nurses really like to do, which is to be hands-on with patients. They can be chronic disease managers. They can help use care pathways to make sure your patients are getting the milestones checked. If, for example, with diabetes, that they're calling them back, getting them on the diet, helping them get their insulin correct, and escalating things into other parts of the healthcare system when referrals are difficult. The pharmacist moves from being a consultant and doing basic refills to actually helping again with hands-on care. They can do medication management. They can look at interactions and refills, and help you with, especially with the more difficult patients who have renal failure and other problems that require advanced medication management. And then we want to embed in the office behavioral health and social workers, and with the help of AI, we can help them do better social care integration, plug patients into the resources they need in the community. The physician's role also changes, and instead of being solely an information gatherer or writing notes, then you really become a relationship manager. You're somebody who's working on relationship with the patients, who's helping them with their difficult questions. You have more time face to face. So this is the vision of an integrated and redesigned workflow. And I want to give an example of how that might work in the office. So we talked at the previous session about workflow that I did in the residency to improve our intake of obstetric patients. And I want to give an example to talk about how a common workflow in primary care, the annual wellness visit or annual visit with your patient, can be re-engineered to make use of AI and to also create much more office time for the primary care physician to have with patients who need the solution healthcare, the diagnostic work that is actually requires an advanced degree. So in the primary care wellness workflow, we have the patient come in and see the RN or the MA for consultation a week before they actually see the physician. And the advantage of this is that the RN or MA can do the pre-visit questionnaire on tablet or on paper. They can get the patient all queued up for their lab work and their screenings that need to be done before the physician talks to them. They can do counseling for fall risk, for diet, for exercise, for tobacco cessation, and nurses are trained to do this very well. In fact, I think most of the nurses I've worked with do a much better job of this than the physicians who are really spending most of their time during their educational training, learning how to be good diagnosticians rather than good patient educators. So then the patient comes back in a second week and the physician can review the results and address their concerns. A lot of the lab work is back to be discussed and the follow-up and referrals can be arranged at that point. If this is a Medicare wellness visit, an RN or a pharmacist can do the intake, and that can be billed as a separate visit in the first week, and then the provider or the physician can do a problem-focused billing on the second week. And of course, if it's all capitated, then it's all included. Compared to AI scribes, which maybe save a physician 1 or 2 minutes per visit, this, in my estimation, saves me about 20 minutes with the patient. And the 20 minutes I do have with them, instead of a 40-minute visit, is really high quality visit because I have all the information available that I need. And if you add AI in the mix, you see that we have the pre-visit questionnaire and some AI analysis in the mix. The RN or the MA who's doing the consultation is more likely to have advice at their fingertips for that particular patient's needs. So currently, you can put the patient's information into AI a tap box like Open Evidence or one of the really well referenced uh, uh, large language models, and they will say, well, yeah, this patient should have these tests done. They should have a colonoscopy, that sort of thing. But the AI currently is not ready for prime time when it comes to getting the information out of the patient's medical record. And that's what we really, really want to work toward, is that when your RN or MA sees this patient, the AI is going to say, hey, this patient has a family history of colon cancer. They've had polyps themselves. Doing a stool test for colon cancer is not adequate for them. They need to have a colonoscopy because it's been 5 years since their last one was done. And you want the AI to help you that and not have to go digging through the chart and doing a lot of chart review to figure out what this patient needs at their annual visit. So that's the AI decision report support, and that can work both with the RN and with the nurse and with your physician when they come back for the following week. So this is a very efficient workflow, and it's going to save you more time than just putting an AI scribe into the physician's schedule.
As the office becomes changed in terms of the workflow, then everybody's job is changed. And sometimes this is a reason that some offices don't adopt some of these new technologies, is because software will change the workflow. And even though it's more efficient, the pain of the change may be why there's resistance. And suddenly people are doing a different job, and there may be problems with understanding why that's important. So change management comes in here, and we haven't really addressed that at all. But the new workflow will clearly save as much as 20% of the physician's time in dealing with these issues alone.
When we started by protocol moving some of our simpler visits, like a simple UTI, off of my schedule, then every patient I saw was much more complicated and much more mental work. And by 3 o'clock in the afternoon, I was really exhausted and just trying to get through the last hour or so because the cognitive load on the physician becomes greater. So it's important that when you make these changes, if you're increasing the cognitive load on the physician, that you give them time to deal with that and not say, oh, we've given you all this efficiency, now you can see more patients in the office. That's exactly the wrong thing to do.
Well, I think we can see more patients, and as we're going to talk about next week, there's ways to dramatically increase physician productivity, but it's going to take a lot of workflow change and a lot of tools that are not currently in the EHRs that are in existence. So until those workflow changes and still these systems get better, physicians are not going to be more productive. And I think that's one of the points we're trying to make is that it requires a lot of change, a lot of software, and a lot of time in training to show people how to do the new workflow, and they can become more efficient. And that's the future.
Right. Supports to make the job easier are really important. And I wanted to show one example of that, of how the AI can provide you some help at the bedside um, as to what should be done. So let's talk for a minute about the role of nurse practitioners and physician assistants. This is really important, and we certainly would not have any primary care in northern Maine, where I live, without the nurse practitioners and physician assistants in our organizations. They were originally licensed to extend physician capacity, but I have to say that they do a great job of providing education and ongoing support to our patients, mainly because of the nursing background, and they're really helpful at chronic disease management. The challenge comes up when you have a patient that has some individual or personal um, characteristics that need to have some judgment, and nurse practitioners and physician assistants are good at that, but it would help them to do their job to have better support. Here's an example of that type of support. This is an AI scribe that is available now from Open Evidence, and I've been using this in the free clinic. Larry Weed came and talked to us at the residency 30 or 40 years ago and introduced the idea of a problem knowledge coupler, where you would put the problems that the patient has into the computer and it would give you a list of differential diagnosis and some advice about what to do about it. And that's been a sort of a long-standing dream of computerization for many, many years. But what we have now is a good step in the right direction. This is a patient I saw who was in for an annual check and had some individual things that uh, needed to be addressed. And one of them was he had a renal cyst. So when I do the AI, use the AI scribe, we're just talking in the room, and the AI scribe writes down what we're saying and organizes it into a note and gives me an assessment and plan. The great thing about open evidence is if you identify what the problem is, the AI can go into the literature and say what the guidelines support. And so in this example, we were talking about the patient's kidney cyst that had been previously diagnosed and what should be done about that, and that we were going to schedule a follow-up for it. And the AI gives me a little red note down here that doesn't go into the patient's final note, but it says current guidelines state that a simple Bosniak 1 to 2 renal cyst does not require follow-up imaging, but repeat CT is reasonable if you're uncertain about the cyst complexity or if it was a 2F lesion, which in this case it was a 2F lesion. So it gave some advice about whether or not imaging would be necessary, and some further information to try to help me make that judgment. And that was really helpful. And so I've started looking at this toward the end of my visit before the patient leaves. And it just helps to remind me that there may be other things I want to do. There may be an additional test I want to order, or it will just give me some reinforcement that I'm on the right track. This could be improved with integration in the EMR. Right now, the AI only knows what we're talking about in the exam room. But if it was hooked into the electronic health record and it knew that the patient, it could see the patient's last CT and when it was and what the date was and what the cyst showed and what the previous plans were, then the advice it would give us at the point of care would be even better. So that's the hope for the future. We have to have some work on trusting that advice. We have to know that the data in the EHR is reliable and something we can actually act on with some trust. And one of the long-term concerns about this is that we don't want to let the automation bias influence the provider too much. So I make my decisions about what I'm going to do with this patient, and then I look at the what the AI scribe says to sort of get some reinforcement as like a little second opinion there. But we don't want to have um, anybody, physicians, providers, nurses or RNs who are using this type of AI guidance, do it without any kind of judgment or overseeing. We have to use
You
our
make
brain.
you make a good point about it needs to be integrated into the EHR. And I think it kind of goes back to one of the problems with the EHR. It was kind of brought in very quickly, and I would suggest it was done before studies of the actual workflow by the physicians was undertaken, in which it was just brought into the exam room when physicians really didn't know what to expect or how to use it, and that created a lot of problems for a number of years and still has. I know that many of the tools that we've talked about are not integrated into the electronic health records because they were basically tools of billing, and they were bought by health systems to improve the billing, not to help physicians see patients. And that disconnect has really resulted in a lot of problems that now people are starting to realize are important. And I think that's what we're talking about, is how to integrate these tools into the HR so that the AI can actually make the physician a lot more efficient, which I believe it can. But again, it's a change in the workflow, it's a change in the software, it's adoption of new tools, and it's retraining of the staff. And it's a massive undertaking. But given the problems that we see coming with lack of access, there's really no choice. I think, and that leads us to what can the AI do to help a physician, and that gets us to the last form of healthcare, the the solution healthcare, and these of course are conditions that Dr. Christensen describes as really difficult, and certainly they're difficult to diagnose, they're complex, they have a differential diagnosis, they're hard to treat, the need for resources is unknown, the time of care is uncertain, and the cost is unknown. You've got uh, conditions like fatigue, falling, fainting, chest pain, seizures, immune disorders, and cancer. And clearly, these challenge even the best clinician. Wouldn't you agree, Charles?
Yes, these are situations which require judgment. So the AI is very good at memory and at finding information and comparing to guidelines, but it's not very good at judging what your patient's risk is. And so these are situations where looking at risk, looking at benefits, making those types of complicated judgments really require somebody with training and experience to get the best input from the scientific data that we understand for treating a particular disease.
And I think that's what we're going to talk about next week. And I think that's summarized by this slide, the healthcare teeter-totter, which if you look at value healthcare, I think the robots can really help us with that. If you look at network chronic disease, I think you've demonstrated really nicely that the humans and the robots can work together to make it a lot more efficient. But when you get to solution healthcare, we're going to talk next week how the robots have a limited role, and I think that's where we need to realize that humans have to be in all these parts of healthcare, but to differing degrees. And understanding this will help us to implement AI solutions in ways that actually does increase efficiency. And we're going to study that next week. Charles, any thoughts as we close?
No, no, I think that covers it pretty well. And thanks everybody for listening.
And we'll see you next week.